Dr. Gashishi. Thank you very much for the opportunity to give them wisdom to do what they have to do for us today and let this meeting have a great impact on us in subsequent years in East and West Africa. Thank you, Lord, and come and take control of this meeting in Jesus' name. Amen.
Amen. Amen. Amen. So I'd like to welcome everyone to the Preventing Cervical Cancer Progress in East and West Africa and the Way Forward. This program was organized by the Standing Committee on Public Health, MSAKE, that is Medical Students Association of Kenya, and FGMSA, Federation of Ghana Medical Students Association. So it's a collaboration. And also, we also have the Integrated Cancer Research Foundation of Kenya also collaborating with us for this webinar. This webinar promises to be a very insightful one as we glean wisdom and insights from both countries and understanding what is happening on the ground as public health professionals and also as students and as future doctors and physicians. So I'm not doing this alone. My name is Jason Selom Kwame Anyable. I'm the National Officer for Public Health at SCOPH-FGMSA, and I'm doing this with Sylvia Ntamwiga. Sylvia, could you kindly unmute and introduce yourself as well?
Hello everyone, I hope you're well. Yes, I'm Sylvia Ntamwira from Kenya and I'm the National Officer of Public Health in the Medical Students Association of Kenya. And I'm really happy and delighted that you all are here, even for this collaboration with my friend Jason and the team. We're really happy to host you all, and I'm really looking forward to the lessons we will learn. Feel free to just interact in the chat comments and even asking questions, so that at the end of the day we are all going to come out of this place more equipped and more with more understanding. Thank you.
Thank you very much, Sylvia. So, Sylvia, before we get into the session, I think people would like to know what MSAKE, SCOPH, know what MSAKE is and what SCOPH is, SCOPH MSAKE is, and I also speak about what FGMSA is. So, Sylvia, could you kindly tell us what MSAKE is and what SCOPH MSAKE does, so people can have understanding of the organizers of this webinar briefly?
Okay, thank you so much once again. So MSAKE is the Medical Students Association of Kenya. Yeah, Kenya is in East Africa for those who don't know. And we are under the larger umbrella known as the International Federation of Medical Students Association, IFMSA. So COPH is one of the standing committees that is in the IFMSA, and even we adopted in the Medical Students Association of Kenya. So in MSAKE, we have 7 standing committees. So we have SCOPH, MH for mental health, we have for human rights and peace, we have for research, we have for medical exchanges, we have for even professional exchanges, and reproductive health rights and aid. So for SCOPH, what we mainly work on is public health. Yeah, public health engagements through, we've been doing webinars from the time this tenure started last year in January, to holding medical camps, to having volunteering in terms of walks and talks. So that's mainly what we've been doing, and I really have a big heart for cervical cancer because it's one of the cancers that we can easily prevent.
Okay. Thank you, Sylvia, for that. So I also briefly like to talk about what SCOPH FGMSA is. So SCOPH MSAKE follows the same structure that SCOPH-ICRF follows. We have various standing committees, but we are under the Federation of Ghana Medical Students Associations. So the Federation of Ghana Medical Students Associations is basically an association of smaller medical associations, medical school associations. So we have Kwame Nkrumah University of Science and Technology Medical School, Accra College of Medicine, University of Cape Coast Medical School, University of Development Studies, um, um, we have Family Health Medical School. We have University of Ghana Medical School. So we have seven medical schools currently in Ghana. So that is also how we run, and we focus at SCOPH. We focus on issues of public health importance. So we use the WHO's criteria of issues of public health importance, and we kind of duplicate or replicate something that the WHO do, and we do it in our students associations to equip all of us as medical students to understand public health, to understand health in its entirety, and also to understand public health and how we can integrate that into our practice later in life. For those of us who are already professionals, I would also like to say it's very great to have you here. We would like to learn from you. And also for those of us that are students, you can always text in the chat box if you have any question, and our knowledgeable speakers will respond to you. So since this is a Ghana and Kenya collaboration, I don't know if Sylvia is still on the call, but the little I know of Kenya is I know there's a greeting in Kenya like Hujambo. I think that's for hello, Hujambo. I hope if there are any Kenyans here, can you kindly wave or send any emoji or show your reaction that you're here? Are there any Kenyans in the house? Are there any Kenyans with us? O- Okay, okay. Could you send more reactions? The Kenyans. Did I say well Hujambo? Am I right? Yeah, Hujambo, 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 Hujambo to all the Kenyans. In Ghana, I don't know which of the greetings to use. But I'll first use Akwaba, Akwaba. So we use Akwaba in Ghana. Are there Ghanaians here? If there are Ghanaians here, could you send sticker? Could you wave? Could you send a reaction? Oh, no, Aquaba is with a B, so it's Akwaba. Aquaba. Yeah, that means welcome in Ghana. So I think this is something the Kenyans can learn, and we've also learned Hujambo. Hujambo, that's Swahili. Oh, Jambo. Okay, okay, Jambo. Okay, Jambo. So if there are any Ghanaians here, could you kindly send a wave, a reaction? Um, we are so happy to have you here. So happy to have you here. And as I said, oh yeah, as I said, we are not doing this thing alone. We are doing it in collaboration also with the um, oh, I probably have to type. The Ghanaians can help the Kenyans in the chat box. It seems they are misspelling Aquaba, so the Ghanaians can kindly help the Kenyans in the chat box. It's Aquaba. Yeah, that means welcome in Ghana. That's Akan dialect. Okay. Yeah, so we're not doing this alone. We are doing this with the Integrated Cancer Research Foundation of Kenya, and we are also happy to have them on board. So, as I said, the title of our webinar is Preventing Cervical Cancer, Progress in East and West Africa and the Way Forward. So, what we want to know or what we want to get from our session is we know we're in the Cervical Cancer Month, and we know that there's been so much publicity about cervical cancer, but now we've had a collaboration. We want to know what is working in both countries. What is the state of cervical cancer, both preventive, both treatment, in its entirety. We want to know the progress in East and West Africa. Since we know that cervical cancer is one of the most preventable diseases that affects a lot of people, both in Kenya and in Ghana. So we have our wonderful speakers, and in due time we'll introduce them, and they would have the floor to give their sessions. Or can I get a last reaction for both the Kenyans and the Ghanaians? Then we can move straight into our session, wasting no time. Hujambo, hujambo, hujambo. Yeah, hujambo. All right. So now I would like to invite the first speaker for our session. So I'd like to introduce our first speaker for the session. So for our first speaker for the session, he's a clinician and a cancer and universal health coverage advocate. He's the youth representative in the Commonwealth International Task Force on Cervical Cancer Elimination, a task force designed by the Commonwealth Secretariat to address the high number of cervical cancer cases in the Commonwealth countries. He is big on cancer research as a great strategy in the fight against cancer. He has contributed in the reviewing of the Kenya National Cancer Control Strategy 2003 to 2027. In his words, and I quote, I strongly believe my main purpose on this beautiful planet is to make meaningful contributions towards solving the mystery of cancer that is wreaking havoc all across the world. Ladies and gentlemen, we have a very wonderful speaker in our midst, and the quote he used at the end just describes his love for cancer research and his love for solving the mystery of cancer. Without wasting much time, ladies and gentlemen, with a show of stickers, reactions, waves, let's welcome Mr. Gideon Gachichi, who is from Kenya, our Kenyan speaker. Let's flood the comment section with stickers, and let's appreciate our speaker. Mr. Gideon Gachichi, I hope
Yes,
I got the name right. Sir.
yes, Gashihi, but it's okay.
It's wonderful to have you with us. It's really wonderful to have you with us.
Okay, okay. Thank you so much. It's such an honor to be invited to be a guest speaker in this special meeting. So if you allow me, I can go ahead and share my slide.
Yes, sir. Yes, sir. Please, the floor is yours.
Okay. Hi, once again. Good afternoon, good evening to my colleagues in Kenya. So my name is Gideon. I am a clinician, as I've been introduced, with over 5 years experience in teaching medical student at the university, practicing, and also advocacy, or being an advocate of cancer, and lastly, being a cancer researcher. So I've been honored to have worked in several organizations. So I've worked with the Commonwealth, with the WHO, a bit of consultancy, and also with a local NGO that deals with cervical cancer. So without wasting time, let me just delve into the presentation. So I'm going to talk about cervical cancer, just to discuss the status of cervical cancer in Kenya. Apologies, some of the things that I'll say might not appear on the slide, but they will be based on the experience I've had having worked in the cancer space for over 5 years. So cervical cancer is, as I think all of us know, that is a cancer that occurs in the female lower part of reproductive system of a female, that is around this region. I don't know if I have my pointer. So, and this cancer is one of the few cancers that can easily be preventable, based on the several preventable measures, including screening, vaccination, and also early treatment. In Kenya, let me just give us statistics. In Kenya, we have cervical cancer is the second most prevalent case cancer, um, uh, uh, occurring around 5,000 cases per annum. And out of this, cervical cancer also is a most high prevalent in terms of mortality. So in Kenya, around 9 women lose their life because of cervical cancer, which is quite unfortunate because this cancer, as you said, is something that is preventable. Um, Cervical cancer in Kenya, just like in the world, it occurs mostly among women of age between 35 to 45 years when they are at their productive stage of life. Unfortunately, in Kenya, most of the diagnoses are usually made very late in the communities. Rarely have I ever come across someone with cervical cancer. I only came across one case. The lady was around 19 years old. But most women that I've come across are usually between 35 to 45 years. So I'm trying to look at where Ghana is. I think you're quite below the statistics of Kenya. Kenya, we have a huge population of women with cervical cancer. And these ones can be explained by some of the risk factors that we are going to mention. And of course, cervical cancer is caused by a cancer that has a known cause, which is HPV. And there are so many variants types of HPV, but the high variant that associated with cervical cancer is HPV 16 and 18, which we did a research here in Kenya, and we saw they are actually among women who are just walking around. Most of them, they have HPV 16 in our population. So the reason why you're seeing this Kenya having more prevalence of cervical cancer, one of the things is because it's just there, but the good thing is that body usually clears HPV within a course of time if someone has a strong immunity. But in our case, is still very prevalent. The second thing that causes cervical cancer to be common in our setting is smoking, though not that common. The main thing that I've seen is HIV. HIV is very common in our population. We have around 1.7 people living with HIV in Kenya. That is approximately 3% of the general population. So you can imagine out of these 700, around 800,000 women have HIV, and therefore HIV and HPV are they usually uh, they usually coexist together, and they tend to increase risk factor for each other. Then we have sexual behavior. The more partners you have, the high chances you contract HPV. A family history, not that strong associated. Low socioeconomic, which can be tied with sexual behavior, and also inability to use to access preventive strategies of cervical cancer. Moving on to an area where I have been working for, I think last year was in the HPV space. So I've been working in several counties in Kenya, it's like state in Ghana. So here in Kenya, the HPV vaccine was introduced in 2019. Before COVID, the uptake for HPV1 was around 45%. HPV1 is the first dose. So usually in Kenya, we give two doses. for girls between 9 to 14 years, and these doses are spaced at an interval of 6 months. So in before COVID, it was around 45% for the first dose and 38% for the second dose. Then after COVID, things went a bit haywire because of the issue of vaccines and the myths and misconceptions that came with it. So uh, the uptick really went down. But after around 2022, the last data that I saw, the uptick for first dose has really improved because of a school-based program, whereby nowadays health workers are facilitated by the government and also NGOs to go to schools to vaccinate girls. So we have 78% for HPV dose 1 and 30% for the second dose. The reason for the second dose having low uptake is because of a high failure rate. But the good thing is there was a research which was done in 2022 here in Kenya, and it showed that HPV, even if a lady just gets or a girl just gets one dose, it can still be effective. So I think the WHO has already published that, and they have recommended that even having one dose is still effective. So that is the status of HPV vaccine in Kenya. Of course, the percentage is supposed to be high. We know there is a strategy developed by WHO which state that for a country to eliminate cervical cancer, they have to adopt the 90-70-90 strategy, whereby 90% of girls have to be vaccinated, 70% of women have to be screened, and 90% of women have to access treatment. So as we are at 78 and 30%, which you can clearly see is below the 90% target of vaccination. Some of the reason why we have very poor uptake of HPV vaccine, apart from myths and misconception, the issues regarding religious beliefs. There are issues regarding accessibility to vaccine, and also facilitation of healthcare workers to go to school sometimes is an issue. So that is where we are in terms of HPV, but I can say this is one of the program that is very effective, and majority of the communities in our countries have really uptake this program. The other ways in which we can prevent, I've said you can vaccinate, you can screen, and also you can treat those ones who are who we get they have precancerous lesions. They usually treated in Kenya. What also I've been doing for the past 1 year is we have been moving around training nurses on how to treat women who have precancerous lesion. And then there are obvious ways in which you can prevent, like you quit smoking, you limit the sexual partners, you try and have safe sex, and of course you have said about regular screening. These are the vaccines that are in the market, but in our country we have been adopting Gardasil. Gardasil is a quadrivalent vaccine, so it prevents 4 variants of HPV. The other thing is signs and symptoms. Most women, as you have said, in Kenya, they come with late diagnosis because they don't even know that they have some symptoms like discharge from the vagina, bleeding, low abdominal pain, and they might just think is either a urinary tract infection. So before they move from especially women in the remote areas, before they come to the urban areas where they can access maybe advanced treatment, advanced screening, takes a bit of time, and that is why they they usually diagnose with they usually come with late diagnosis. But the good thing is, we have a lot of non-governmental organization in Kenya who are moving around educating women, and I'm happy to report that nowadays, if you ask majority of women, they will have an idea what is cervical cancer. But if you go to remote areas, most people don't even know what is cervical cancer, and the kind of the kind of implication it has on our women. So here the signs: bleeding, intermenstrual bleeding, pain during intercourse, and vaginal discharge, postmenopausal bleeding. The late stage where most women show up with include pain, sciatica pain, which is obstruction of the ureters and the rectal area. Um, these are just continuation of the signs and symptoms. I won't dwell much into those ones. Let me move on to screening. In Kenya, we have adopted all the screening methodology. So we do screen using the VIA, we do screen also using the pap smear, and lastly, we screen using a HPV test. So for the VIA, is the cheapest, and most government hospitals in Kenya, they have VIA as a mode of screening. So VIA stands for visual inspection with acetic acid, whereby you open the vagina, you visualize the cervix, you apply iodine, and then you see if there are any changes. And then we are trying to introduce HPV screening, especially HPV tests, especially the self test, because we realize using the VIA or pap smear, they are usually more invasive, and most women tend to shy away from that. So in actually last week on Friday, we were in one region in our country where the government was adopting the HPV test, self-testing. So a lady is given a brush like they insert in their genital area, and then it touches the cervix. They brush a bit, then they put it in a transporting bottle, and then it's taken to a lab for test. Though the HPV is very expensive, I don't know about Ghana, but in Kenya it's very expensive, and therefore is not that accessible to majority of women. So here we have embraced VIA and then pap smear. Rarely would you find most facility uh, doing HPV test. The criteria for screening is any woman in Kenya, any woman who is sexually active, they are eligible for screening. And we screen up to the age of 49 for the VIA and pap smear, and then sorry, for the HPV tests, and also pap smear, we screen up to 49, then 50 and 60 we screen for VIA. Once someone has been screened for VIA, we usually have five years interval, but for HIV patients, we screen them yearly. I forgot to mention, because of the huge population of HIV patients, for girls who are already seroreactive, they're usually given 3 dosage at 0 months, 2 months, and after 6 months. So for them, here we screen HIV positive after yearly. These are the tests I've talked about, and the HPV testing, which is what the WHO is recommending, but the test is extremely expensive. Not extremely, but it's a bit expensive for majority of our population. So here is the procedure of collecting a pap smear, and then this is colposcopy for anyone who turns positive for the VIA. We usually have colposcopy services. Once a diagnosis is made, now the process of treatment usually follows. And the good thing is the government of Kenya has really invested in treatment. We have a lot of hospitals with radiotherapy machines. We have several hospitals with PET scan, and we are also one of our major referral hospital has a cyberknife brachytherapy machines. So in Kenya, access to treatment, compared to maybe the time I started this cancer, I joined the cancer space, things have really moved very fast, and the government has invested a lot in making treatment and diagnosis accessible to the population. So this is how a VIA slide will a VIA will apply when someone is examining using a colposcopy. So once it's done, treatment can be availed. Said here we have treatment for precancerous lesions are very much accessible, and through partnership with various organizations, our nurses who do screening using VIA, they have been trained on how to treat. So we're anticipating maybe in Kenya in some few years to come, the issues of cervical cancer will reduce because of the interventions that the government and other stakeholders are putting in place. Treatment will depend on stage. Treatment will also depend on the women preference and also possible side effects. So, because of the fact that we have most women coming with late stage diagnosis, then there's an issue of survivorship. So, this is where this year I've decided to focus myself on after seeing a lot of women uh, 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 struggling after diagnosis or even during the process of treatment. I'm working nowadays with the survivors, and survivorship is something that I would really encourage you as medical students. Once you probably graduate and you start practicing, make sure you also take care of these patients post treatment or even after diagnosis, because a diagnosis of cancer, most of our people perceive it as a terminal thing, and therefore they tend to be having low emotions, and so the government even in Kenya and the WHO have draft something on survivorship because of the things we have been survivor. So survivors, once someone has cervical cancer, you have to make sure you take care of their sexual life, because they're still wife to someone, and in an African set up and religious like Christianity, they still want to stay with their husband. So you have to take care of the sexual life. You have to train. We usually talk with the caregivers and talk to them about how to live with this patient. Lifestyle changes, you have to address that relationship, how to take medication, and then also you have to talk to them about follow-up and treatment. That is the end of my presentation, and thank you so much.
And let's give a big round of applause, a reaction. Mr. Gideon Gachihihi. I have to get this name
Yeah,
right. Mr. Gideon
yes,
Gachihi.
Gashishi.
Have I got
Yeah,
it right? Uh, yeah,
yes, yes, yes.
Gachihi. And Hujambo is what they say in Swahili.
Yeah, Jambo, Akwaba.
Hujambo. Yes, Aquaba, Aquaba. That was an insightful and concise yet precise presentation. So I'd like to now move to the question and answer session. Um, if the audience have any question, they can raise their hand so they'll be unmuted, or then you can type it in the chat box. So now the floor is open for questions. But I have some questions myself, though. But I'd like to give the audience the chance to ask their questions. Okay. Yeah, Angela, you rose your hand, like your hand was up. Angela, you can unmute and speak.
Okay, so I wanted to know, you mentioned that the who recommends HPV tests mostly for cervical cancer testing, but because of the constraints most people usually face, you resort to the other test, the HLP test. Sorry, I'll get that one. Please, can you correct me on that one? What's the name of the first test you mentioned, please? I missed it.
Via, via, via Vilio Pap smear.
Okay, the pap smear. Oh, okay. I wanted to know if it has, even though we resort mostly to the pap smear, does it have um, a high sensitivity as okay. Is it also able to easily pick up many people with cervical cancer, even though we cannot usually resort to the HPV? Does it also really help? Are there cases where we miss patients because we can't use the HPV test? Or so far, the success rate in picking up all patients with cervical cancer with a pap smear has been good. So it's still a very effective method.
Okay. Can I go ahead and answer this?
Yes, please.
Okay. Thank you so much, Angela. So for the screening services, I've said we have a HPV test, we have VIA, and we have Pap smear. So um, you can imagine for the HPV test is basically you are getting sample from someone's cervix, and then after that you are looking whether they have DNA or RNA um, of genetic materials of the HPV virus. So HPV test is up to the age of 49. The reason why it's done a bit late is because anyone who has had sexual encounter, especially someone below 29, they will have HPV positive, because we have said you will almost 80% of the general population, they usually contract HPV in their life. All women, 80% will contract HPV. However, the body will be able to is able to clear HPV in again 80% of that population within a few years. So HPV test by itself is usually a good a broad screening method, because you can be able to see whether someone has HPV in their cervical region. And once you find someone has this HPV, then you can move on to the other test like the pap smear and so on. So so the reason why WHO is recommending that is because you can imagine subjecting someone to pap smear or VIA, which are invasive, and they don't have HPV virus in their cervical region. So the HPV test then becomes a very vital first step for screening all women, so that you know, this among these 100, I only have 10 who have HPV virus. Then these ones I can move on to do a pap smear and other tests. But the way currently I think in Kenya we are working is that we are doing VIA for all women. We are just doing for all women whether you have the virus or you don't, which is quite unfortunate, because if you don't have the virus, then there might not be need for you to do the screening per se. So uh, so it is not a disadvantage, but is good in a developed setup, so that you don't have to subject all women to invasive screening test. Yeah, so it's not disadvantage per se.
Okay, thank you very much. Thank you very much, sir. So just to chip this in, um, our speaker also works with the Integrated Cancer Research Foundation of Kenya, and a message has been put in the chat box where you can know a bit more about Integrated Cancer Research Foundation of Kenya and the work it does. And there's also Mesha Cancer, which is a cancer education project by ICRF of Kenya. And they've also put in their links, so you can kindly go to the chat box and see the links. The links have been put there, and the message has been put there, so you can read those as well. All right. So now, say there's another question from with Mwangi, and she's asking that is the HPV vaccine still effective when you get it as an adult? Because she's saying that she mostly sees those programs targeting teenage girls. So she's asking if it's still effective for adults.
Okay, so um, the WHO recommends that you can vaccinate women up to the age of 26. So let me to vaccines are given before exposure. You get a vaccine for you're given vaccine for BCG when you are when you are you're still a neonate to prevent you from contracting tuberculosis. So vaccines are given pre-exposure to a certain virus or bacteria. So in the case of HPV, which is largely sexually transmitted, that is why it is given to young girls between 9 to 14, assuming that they have not had any sexual debut, and therefore they will develop immunity before they become sexually active and they contract the HPV virus. However, there is a leeway in terms of effectiveness of the vaccine. It is more effective for people who have not been exposed to the virus. However, the WHO says you can go up to 26 years, but it will not be as effective as someone who has not been exposed to the virus.
Okay, thank you. I think that was well said. I think Ruth's question has been answered. Are there any other questions? If there are no other questions, then I think we can move to our next speaker from Ghana. Okay. Any questions? You can put them in the chat box, or you can raise your hand to me and mute you. Okay. Seems there are no questions. Okay. So let's give a hand in with reactions. Let's give a wave. Let's give a hand for our first speaker, Mr. Gideon Gachihi. Yeah, I think I got it right now.
Yeah.
Let's give a hand to him. Okay. So Mr. Gideon would have to leave very soon to attend another meeting. So he'll be leaving us soon. That's why we had this question and answer session before our second speaker. So our second speaker would speak, and our second speaker would also answer questions generally and also from what has been spoken. So you can still, if you still have questions and Mr. Gideon is not here, you can still ask them to our second speaker and you answer them. Okay. Thank you very much,
Okay.
Mr. Gideon. We are honored to have you, and all the best, because we really like the last quote you had in your bio that you really want to help eradicate cancer. And we thank you for all the work you do. Thank you very much.
Thank you.
Asante
Thank you
Sana.
so much. Okay, okay. Thank you so much for the opportunity and thank you for listening and the question. I really appreciate. I'll be joining. I might not be able to talk, but I can just follow audially. Thank you so much.
You are very welcome, sir. All right. So I'd like to call on Sylvia to um, introduce the second speaker. So Sylvia, the floor is yours.
Okay, thank you so much. If you can hear me, just give a thumbs up to ensure we are all together. Nice, nice, nice. So now on to the next speaker. If you can have drum rolls, it's really worthwhile. Our next speaker is known as Prof. Kwame Adubonsafo. He is a full professor of obstetrics and gynecology at the University of Ghana Medical School, UGMS, and a consultant obstetrician gynecologist at Kolebu Teaching Hospital. He's an experienced fertility consultant at the Holy Care Specialist Hospital in Accra, Ghana, with extensive clinical expertise and academic credentials. He is an alumnus of the University of Ghana and Utrecht University in clinical epidemiology, where he did his master's and PhD Professor Adu Bonsafor has a distinguished biomedical and clinical research portfolio focusing on maternal health, particularly hypertensive disorders of pregnancy, preeclampsia, cesarean sections, postpartum hemorrhage, preterm birth, respectful maternity care, and maternal morbidity mortality. Since 2015, he has served as a consultant for the WHO, contributing to various maternal and reproductive health initiatives, including advancing respectful maternity care globally. His work reflects a deep commitment to improving maternal health outcomes through clinical excellence, impactful research, and international collaboration. So yes, that's our speaker, our second speaker of the day. And could we just upload him with some flowers, some reactions, even as we welcome him to take the stage? I believe that's really worthwhile. We're really honored to have you here, Prof. Kwame, and looking forward to just tapping from the rich knowledge and expertise that you've been having. Yes, thank you so much. You're welcome, sir.
Yeah, thank you for the introduction. I'm still having a little challenge with sharing, so maybe I can share with one of you quickly, and then because my computer is restricting me, I don't know why. So what can we do?
And please,
Um,
Prof, you can try now.
Yeah, when I tried it, it's giving me restrictions. So,
Eh, And please,
yeah,
Prof, that was because
it said can't
you,
share your screen, maybe due to system preferences or something like that. So that's what I'm having now. I can quickly share
um,
with you, and then you can show it for me.
yes, Prof.
You have an email or something or anything.
And please, Prof, you can share it with Angela, and we'll be
I've
able to
sent it
do
to her already. I've called her several times. She's not responding. Even before, I've sent it to her by
Okay.
email.
Okay.
Oh, Prof, please, I've not received it yet. I'll check it right now. Sorry about that, please.
The email that you sent me with, I've shared with you. So if you can share with me, I'll be very. Uh,
Yes, please, Prof. Yes, please. Sorry about that.
And please, Prof, please,
yeah.
while we wait for Angela to sort out, please, the participants from Kenya would want to know how much you know about Kenya, or if you know anything about Kenya. They want to they want to find out from
Oh,
you.
about Kenya.
About Kenya.
Oh, Kenya is, I think it's in the eastern part of Africa, and I've actually visited Kenya before. I think on 2 occasions, and it's a nice place. Um, I know their president is Kenyatta, right? And or they have changed it. They have changed him.
we
Sylvia, you would have to
changed.
answer.
Oh, you changed. Who is the president now? I don't know the current president, but I know Kenya. I saw and I heard you were speaking some Swahili. I know Swahili in some of their even universities they use Swahili in teaching, and I was so impressed that they use local languages. I mean, a local language to teach. And I was in Nairobi, I think on 2 occasions, and it was great. So that's what I know, and I have some friends. I met some friends there. It's a nice place to be. Maybe one of these days I might go there again. Okay, I'm told the current president is His Excellency William Ruto. All right. So even before, can we start? even before Angela shares it, or we should wait a little while?
Please, Prof, you can start. I'll be sharing the slide very soon.
Have you got it?
Yes, sir.
Right, that's okay. All right, that's fine. Kindly put it on PowerPoint presentation mode. All right, so thank you once again for the opportunity to speak. Today we are going to talk about cervical cancer, especially from the Ghana's point of view. And look, globally, we can see that cervical cancer is a very big issue because it's the fourth most common cancer apart from breast cancer, colorectal cancer, and lung cancer in general. In Ghana here, cervical cancer is the second most common cancer in females after breast cancer, and is causing a lot of morbidity and mortality. And if you look at our statistics, please, have you shown it? I can't see, or you are still struggling?
Please, Prof, can you see it now?
Yeah, it's okay. So the diagram we see is a global picture of how cervical cancer is distributed, and you can see areas where you see the deeper ones are showing areas where you can have cervical cancer being more prevalent. So I want us to move to the Ghana one where you can see that in Ghana, for instance, kindly move on. Cervical cancer is causing a lot of mortality and morbidity because if you look at the total population, female population as of 2019 was about 15 million, and you can see that we're having a lot of 80,000 deaths. But when we come specifically to cervical cancer, the crude cervical cancer incident rate was about 18 per 100,000 women, and age-specific or standardized cervical cancer incidence was about 27, also per 100,000 women. If you take 100,000, even though you see this number to be small, it's quite huge because it's causing a lot of morbidity and mortality. And you can see cervical cancer death as at the year 2019 was 2,200. That was quite huge. And based on that, we have made a lot of attempt to try and improve the screening and also improve public health education and all that. Kindly move on to the next step. And so you can see this diagram tells you about how the areas in Ghana and how screening points are located. It's very sparse, but it looks like we are still doing well. You get to understand why in Ghana we are still having challenges with screening for cervical cancer in the course of the lecture. Kindly move up. And so screening is quite problematic here, even though we keep on providing education and trying to screen. We do not have a well-coordinated screening program as a national program. And so you see that most of these screenings are done by individual facilities, hospitals, private hospitals, and all that. Although it is recommended nationally that we should all be screening. There was a study that was done by STEPS, sponsored by the Ghana Health Service, WHO, and the other group. And we realized that over 96% of women have never been screened in terms of this age group between 30 and 49. This number is huge, and this is quite recent, 2023. And Let's look at how it is distributed. Overall, screening rate was about 4.3% within the range of 2.9 to 5.7, and there was a wide disparity when you compare the urban centers with the rural areas. You see that in the urban centers, about 5%, that was the rate, compared to about 3% in the rural areas. This means that women living in the rural areas are actually having major issue, especially with respect to screening, and therefore the burden of disease is quite huge when it comes to cervical cancer for these women. Kindly move up. And you can see that this statistics is further categorized, as you can see on the screen, indicating that um, between ages 18 to 29, only about 2% of women had been screened. And then you go to 30 to 44, about 3.4%. And you can see that the rate of screening was going up with as the age of the woman increases. And you can see that between ages 60 and 69, that was about 7.9%. This tells us that people are becoming more conscious, especially women are becoming more conscious as they grow, and because that's the time that malignancies or cancers actually also emerge, and therefore it looks like they tend to um, seek for more screening and treatment services. But overall, this is about 3.6. The simple question they asked was that, have you ever had a screening test for cervical cancer using any of the methods that are available in Ghana for screening? And those were the the responses that we got. You can see that, so overall in Ghana here, just about 3.6% of women having undergone um, screening ever in their lifetime. Kindly move up. And then, so you ask yourself, what is the cause of cervical cancer? My colleague presenter mentioned HPV as the main cause. And of course, the same thing also applies to us in Ghana here. And most of them, about 15 to 20% high risk HPV types cause cancer. But as we all know, the type 16 and 18 is the most common one that are associated with cervical cancer, and the two can cause up to about 70% of the cervical cancers attributable to HPV. And you also have low low risk types, and these ones actually cause genital warts, and these are benign conditions that can be treated with um, various modalities of treatment. Kindly move up. So once you get the infection, you see, the idea that we have to remember is that once you get human papilloma virus infection, it does not mean that you have cervical cancer or you are going to have cervical cancer. The main thing is the persistence of the disease, of the infection. Once you have the disease persisting through, that is what will cause that. So if you look at it, only about 10 to 20% of all infection become persistent and result in precancerous conditions that will lead to cervical cancer as well. And you can see that nearly 90% of the infections will clear within 2 years. So it's actually small proportion that will progress to pre-cancer conditions that will lead to a cancer. So it tells you that if we have a chance to reduce or prevent the progression of the disease, then that will be able to prevent cervical cancer. I also always say that cervical cancer is also, some will call it as a sexually transmitted infection, because once you have HPV, is transmitted mainly through the sexual means, and therefore, if we're able to prevent all this, then you are not likely to have the infection. Kindly move up. So you can see that the two main variant, the 16 and 18, after infection, then you can see that these will progress into the cervical cancer, especially if they persist. But on the other hand, if you had the non-cancerous or the benign ones, then they will go on to form or to cause anogenital or genital warts. And HPV is necessary, it's a necessary cause of cervical cancer in about 99% of the time. It tells you that nearly all cases of cervical cancer are caused by HPV, and that is just a point to repeat. Kindly move on again to the next slide. And this slide is quite important. It tells us a lot about the pathogenesis of cervical cancer. You can see the slide on the left side of the screen where you have a female fetus who is unborn. If you look at the first one, it's showing that the endocervix, this is the inside of the cervix, is out, and once it's kind of shown outside into the vaginal area because of the high levels of estrogen. Immediately after delivery and during the pre-pubertal area, you see that then that endocervix will kind of invert in, or it will go in. Then immediately after the time of adolescence, when the female reaches adolescence, then the inside, the inner part of the epithelium will come out again, as you can see here. And this side is going to cause, this is where the columnar epithelium here is going to turn into like a squamous cell, squamous epithelium. So you can see that that process is a metaplastic process, and that is where women are actually highly prone to HPV infection. So that's why, if you remember the risk factors for cervical cancer, early coitus, having sex very early, especially around 12, 15, 16 years, because that's the time that the conversion metaplasia is occurring, and one has to be very, very careful, especially during that time, because then the transformation zone, or the area that is forming the new cervix or the cervical epithelium, is prone to infection with HPV. And so the outside here, as you can see, is the ectocervix, and then the inside, where the initial columnar cells invert to form the external or the ectocervix, is what we call the ectocervix, and that's where some of the cancers can also occur. Kindly move up. So this point has been said already, but just to let you know that when you have this HPV infection, about 20% or 10 to 20% will move to low grade, and subsequently some will even come back or return to a low grade, and then it might also move to a high grade and later to invasive carcinoma. And so the point here is that once you have HPV infection, it means that you may get um, invasive cancer of the cervix. However, there's a lot of resolution. Sometimes, most of it, nearly 90% of it, will resolve, and then the person will be free. It means that we only have about 10 to 20% to deal with. If we can deal with only this 10 to 20% progression, then women will not actually develop cervical cancer. So kindly move up. So the risks have been mentioned already. So what I want you to remember is the early age at coitus, which is something that you always have to remember, especially because of the metaplastic process that is occurring, converting the columnar epithelium into the squamous epithelium in the cervix. And that is the main thing. And apart from that, higher parity or higher number of beds, multiple sexual partners, these are things that we know, including immunosuppression that my colleague mentioned also. Good, kindly move up. So in terms of how the lesions occur, or how the disease occur, it can be on the ectocervix. Ectocervix is the outside part of the cervix that I mentioned, and then only about 20% will go into the endocervix. That the endocervical lesions can be quite difficult to diagnose, because when you have these lesions, sometimes you don't see them on inspection, and therefore you may not be able to diagnose this one. So by the time these lesions become clinical, they have spread to the other part of the body, and that will normally occur as an occult disease. However, you can have other presentations on inspection. You can see that it may look like a growth on the cervix. Sometimes it looks like like an ulcer, like ulcerative lesion, and in some situation, it will not present as either a growth or an ulcer, but it will rather infiltrate into the cervix and it gets into the pelvic side wall, like into the where the ureters are, and that is the one that can also cause a lot of problem because initially these ones may not be diagnosed easily. Kindly change the slide. And in terms of clinical presentation, normally they will come with abnormal bleeding from the genital tract. It may be that you have just a little bleeding following coital activity, or a heavy bleeding following coital activity, or some people may actually have intermenstrual bleeding where they have small bleeding in between their menses when they are not expected to bleed. And also postmenopausal bleeding. In fact, any woman who is in the postmenopausal period and has some form of bleeding, you have to think that this person either has endometrial cancer or cancer of the cervix until proven otherwise. And so that is something that you have to also consider strongly. And another presentation is situations where they'll present with sometimes watery discharge, bloody discharge, and foul smelling, extremely foul smelling discharge. And that is something that once you see that, you should also be able to. So this is the point that as medical students, I think we should take this point and be able to continue with the public health education and also with screening, organizing programs to facilitate that. The reason is that let's face it, our women in the developing part of the world, when they have some of this presentation, especially with vaginal discharge at that age, they tend not to seek help. They may start using like herbal preparations until it becomes worse. There was a patient that I was referred to me from the district, and that patient had seen, it was so painful that she has seen some form of abnormal vaginal discharge, offensive, has been applying medications, herbal medications for that matter, and never um, um, reported to a facility, a hospital for investigation, and only was brought to the clinic after the person had had major bleeding and was severely anemic. And at that point, when we examined the patient, she had very extensive, complex cervical cancer, which has spread to the pelvic side wall and has actually involved the ureters. At that point, it is quite difficult to treat. The only way to consider is radiotherapy, because once the patient presents late, then it's quite difficult to to treat with surgery. So the late presentation of cervical cancer is pelvic pain, low abdominal pain, or urinary symptoms where the person is having acute urinary retention, or they are having fistula and therefore urinary incontinence. But by the time a woman who has cervical cancer presents with pain, let's face it, then at that point the disease has advanced and you are not likely to get surgery for treatment for that person. And so we have to be very careful. Most of the time it comes with bleeding, minimal or maybe heavy following coital activity, or sometimes even after washing, after bathing and washing, some of them will report seeing some blood, and that is one of the main things. Occasionally they may present with um, they may have no symptoms. So that is the asymptomatic presentation. And this may be picked up during routine screening. And that's why we are saying that screening is key. You have to always think about screening our women. And it is said that you can screen women after 20 years or 3 years after initiation of coital activity. So if a woman hasn't had sex before, by 20 years going or 21 years, you should be able to screen. You should start the process of screening. But of course, if a person has had coital activity, then you don't have to even if the person had it earlier, then 3 years after initiation of coital activity, that should be done. This is because cervical cancer is preventable and is treatable, and if if it's diagnosed early, then you can get effective treatment. Unless the person is diagnosed late, that is when it becomes very critical. Kindly move to the next slide. Good. So when you look at it, in this is because you are a medical student, I thought it's better you look at some of the main things that can occur. Sometimes it may be fixed to the cervix, and then it may be fixed to the lateral wall of the cervix, and it may become hard, and sometimes it breaks easily. The lesion breaks easily. So once you have any lesion on the cervix, it is considered cervical cancer until proven otherwise, and then you may see abnormal discoloration there, and that is something that you should also consider. But finally, diagnosis can be obtained using biopsy. You have to always do a biopsy to confirm the histological type. Kindly move to the next stage. And what are the causes of death? Women die of cervical cancer because of renal failure, chronic renal failure, which we call uremia, and the bleeding, and also they get sepsis because in most of the time when they have cervical cancer, it causes obstruction to the some of the urinary tract points, especially the ureter, and can cause stasis, and this will lead to infection. And also the prognosis factors will depend on the stage at which the person present. The patient I described to you earlier on, she presented late and we could not do much. Some of the major complications that can come with the cervical cancer include situations where there's accumulation of pus in the uterus because of the obstruction to the cervix, and that is what we call pyometria. You can have bleeding, urinary tract infection. I've already mentioned fistula, and this kind of fistula it's not a type that you can easily repair. It's quite um, debilitation, and it can cause a lot of issue, and it can be crippling. Kindly change to the next slide. So in terms of investigation, we have already mentioned the fact that you need to biopsy, and also you have to stage it. You need a lot of investigations, including IVU, intravenous urography, to try and locate where the extent of the disease is. And also, in nearly all the time, you need to examine them under anesthesia. Examination under anesthesia is very key because it is said that cervical cancer is diagnosed clinically. It's actually a clinical diagnosis. And so we should be able to look at this. And once treatment is initiated, we have to be able to consider all that. Kindly move to the next slide. So treatment, what treatment can you offer to a patient with cervical cancer? It will depend on the stage. If it's early stage, surgery can be done and the person will be free. In fact, surgery and radiotherapy are the two main treatment options that one can give to people with cervical cancer. If the patient says it is early, but I don't want surgery, then you have to consider radiotherapy because they are equally effective. Just that in the next slide, you'll see the advantages and disadvantages that can come with this. And you could also combine it. Sometimes you can do surgery first, and then you can combine with radiotherapy. When this occurs, the complication or the morbidity associated with it can be quite severe. And so if you can do the surgery can be done and the patient will be fine. The surgery that we do for these women include the removal of the uterus. We may preserve the ovaries and then suspend the ovary up, because if you don't suspend the ovaries up, sometimes if the patient needs radiotherapy, then the ovaries will be bent and it will be useless. And so surgery can be done and then you suspend the ovary, and then it can be quite extensive. And as I mentioned, the age and the stage of the disease can be very key, can be very important in deciding which kind of treatment you want to offer. If you did surgery, that can be good because the woman will think that, kindly go to the next stage, will think that the disease has been removed. The everything is done, because once you remove the surgery, patient psychologically thinks that, oh, I'm okay, the whole cancer has been removed. And however, you can have some complications with the surgery. For instance, you can bleed, you can have infection, you can have edema formation, bladder can be injured, and then you can also have other complications with it. If you did surgery, then you realize that for after some time the patient will be able to um, move about easily if everything has been successful. On the other hand, if you did radiotherapy can cause fistula formation, and it can cause even stenosis of the vagina, and that can even cause problem with coital activity. So all these surgeries are in Ghana. Here we do the surgeries, we do the different types of surgeries for patients with a CA service in the Kolebu Teaching Hospital where I teach and work. We have a radiotherapy center where women who need higher order treatment, who need radiotherapy, are referred to for them to have their radiotherapy. After we have had the surgery for them, if we think that there are some residual cancer cells that need to be treated, this patient will be sent to them for treatment. And then occasionally, the problem we have with treatment in Ghana is that sometimes some women are afraid that when they have the radiotherapy, it will burn their tissues and all that. And some will still um, rely on herbal treatment, which is not appropriate. I had a personal auntie who had CA service, and she was sent to reported to the radiotherapy center for treatment. And upon further counseling and calling all the relevant stakeholders to advise, this auntie decided not to do not to do the radiotherapy and went back home. Finally, after about 3 4 months, she had repeated or recurrent bleeding, and we lost her. And this is typical of the women in sub-Saharan Africa, especially with our culture, tradition, and our religious link or inclination. Sometimes we think that herbal treatment can be quite um, um, important for them than using the radiotherapy or the surgery. Kindly move up. So, having said that, we in Ghana here we actually consider prevention of cervical cancer as key. What we do here is that I realize that our colleagues in Kenya actually do more of VIA, visual inspection with acetic acid. We don't do that much. We do a lot more of pap smear. Pap smear, we do the traditional and the liquid base. These days, most people are moving towards the liquid base. VIA is still something that is done in some areas, but as I said, we don't have a national coordinated program where, let's say, every woman is supposed to have screening of cervical cancer done. And so, because of that, this screening is done in different hospitals and in other private hospitals. They have integrated cervical cancer screening into their reproductive programs. And so, we don't have a well coordinated program. And so, that is our main challenge in our country. And I think that we should consider that. So you can see that a lot of young women and women in general have not been vaccinated, because you can only be vaccinated when your parent can afford, or somebody can afford to do that for you. That's when you can get your vaccination. So we realize that primary prevention is quite key, where we keep on talking about education, and then vaccination for our young women, and even the other type of vaccination. Here we have both the Gardasil in Ghana and also the Cervarix, and then it depends on the choice then that can be given to the patient. But as I said, it's not like a coordinated uh, program, and so it's quite difficult to even know which people have been vaccinated and not. It's not likely to get that kind of data easily, because when people are vaccinated, they keep it like it's known to themselves, and so it's quite difficult. We don't have that national data to share easily. But I think moving on, this is something that we as medical students should consider taking it up and singing the song and talking about this issue to our, our leaders. And so pap smear is something that we do strongly. And when we do pap smear and we have abnormal results, then we send the patient for them to go and have colposcopy. Colposcopy is when you can visualize the cervix under a specific microscope to see exactly what it is. So when you see that, then you can apply your acetic acid or whatever the Lugol solution to the cervix, and then you see aceto-white lesions or areas of abnormality, and that can be biopsied. So normally colposcopy, you do your pap smear. If you see abnormal results, then you go on to do colposcopy. Colposcopy will look at it and then will tell you what each lesion you have. Then once you see abnormal areas, then that area can be biopsied and then sent for histopathology. That can give you an idea what lesion you are dealing with. And the tertiary prevention is where we identify people with cervical cancer early. In fact, as I said, this is a preventable disease, and we should always be able to prevent, and as well as the fact that it's also treatable and the patient can be treated. So once you get them early, surgery alone can be a cure for them. If they come late, surgery plus a radiotherapy can be quite good. And if they come as an advanced disease, then surgery cannot be done. If it's advanced, surgery cannot be done, and you may have to go for radiotherapy. Kindly move to the next slide. So after you have done the surgery, as I mentioned, we keep on monitoring them. There was a patient that we did a VETAM surgery. VETAM surgery is one of the extensive surgeries we do for women with CA service. And then when we did that for her, we did not remove the ovaries. We left the ovaries because she was quite young. She was 42 thereabout, and so we left the ovaries behind, and then we suspended the ovaries in the hypochondrial area of the abdomen, knowing that we were thinking that maybe sometimes the patient might need radiotherapy. So we suspended the ovaries, and it's about 8 years now. The patient looks fine. She still comes for treatment. In terms of coital activity, she's still able to have coitus without issue. She hasn't had any bleeding subsequently, and then she's looking well. There was a patient that, in terms of survivor monitoring, this patient had radiotherapy. She was quite old, like 68, 70 years, and she came in late. So we did radiotherapy for her, and she went through all the processes. However, she developed very bad cervical vaginal stenosis, and it was quite difficult. She also had vesical fistula, vesical vaginal fistula, which she was leaking urine all the time, and so that was quite problematic. She later got bedridden and had bed sores, and unfortunately, after some time, we lost her. So, in terms of trying to prevent and treat cervical cancer, my colleague Gideon talked about the WHO approach, the 90-70-90, which shows that these are related to these three. This is a target by WHO by 2030, that by 2030, 90% of girls should be fully vaccinated with 2 doses of HPV vaccine by age 15. And then also 70% of women, in terms of secondary prevention, should be screened using high performance screening tests at the ages of between the ages of 35 and also by age 45. And in terms of the tertiary prevention, WHO target is that at least 90% of women detected with cervical lesion, or it could be precancerous or the cancer itself, they should receive treatment for this. If you have a precancer lesion, like we call it cervical intraepithelial lesion or neoplasia, These ones you can have less extensive surgery for it. You can do cone biopsy and all that. And these are things that we in Ghana here, we also do this. It depends on the stage of presentation. We do that. Good. Can we move to the next stage? And this is what WHO recommends, that between 9 and 14, women should receive the HPV vaccination. Can have one or two, and you can have two doses at the same time. Even after 21 years, you could still have some um, vaccination. So don't let us think that once you move beyond the 14 critical year period, then you cannot have it. You can still have it, can have the vaccine. Especially, also, let's mention that once you are immune to one type of vaccine, HPV variant, it doesn't mean that you are also immune to the other one. You may still have infection with the other types, and they can also cause infection. I've already mentioned that about 70% is due to type 16 and 18. There are other types, 33, 45, 35. They are all part of it. So please, we need to also keep this in mind. Kindly move to the next slide. And more recently, WHO has stated that a single dose of HPV vaccine can be as efficacious as the 2 doses or 3 doses in preventing the persistence of HPV infection. So even if you can't get and you get one, that is still considered very useful. And a single dose schedule should reduce the program cost and also makes compliance very, very effective. So that's something that we should consider. This more recent information from the WHO, and I thought it would be good to share. Kindly move to the next slide. And so you can either screen, in terms of treatment, you can screen and treat approach. So we have the screen treat approach, where the decision to treat is based on a positive primary screening test only. Maybe you have done a pap smear or VIA or anything, and once you see the lesion, you can do ablative treatment, and that will be done. Where you can do excision, or you can do uh, some ablation like lip or loop on the cervix, and that can be quite good. You can also screen, triage, and treat. Also, in this case, the decision to treat is based on a primary positive test, followed by another secondary test, and then you can now go on to confirm your diagnosis. Situations of where you can do a pap smear, which is positive, you go on to do colposcopy, which will be the secondary test, and then once that is positive, you can have a histological diagnosis, and then you can treat. So that is something that we should consider. Kindly move on to the next slide. So in Ghana, as I mentioned, there's no publicly funded HPV vaccination program in Ghana. We don't have anything like that. But HPV vaccination can be accessible through private programs like hospitals. Um, Having said that, some of the public hospitals and private hospitals have programs that they can help, but we don't have a very well coordinated one for that matter. And therefore, as you can see from what I have said, HPV vaccination is highly inaccessible to a large population of patients or of clients who actually will benefit from it. And that is our main problem in Ghana, because the chunk of our population, women population, actually also live in the rural areas where they don't have access to even communication and also even technology, and therefore they don't even know much about it. Even though we have done a lot of education, public health education on cervical cancer prevention and treatment, and also even causes and all that, we still have a lot of people who do not know much about cervical cancer in the country. And this is the point where we need to really look at it. So the case that I talked to you about, let's not think that only women who are uneducated are affected. That woman I mentioned was a highly educated person, but sometimes they feel this is very far from them and they are not likely to develop the condition. And that's when issues crop up. So that is something that we need to be mindful. And therefore, we need to continue with education and education, and also bring screening to the doorstep of most of our women. There should be a very innovative approach of screening our women. It looks like we've done the traditional one for quite too long and it's still not working. Can we change our approach? Can we do something different and to help with the screening and vaccination and even treatment? They don't come early. As I mentioned, women, some of them when they have even bleeding or some vaginal discharge, they think it can be treated with some herbal preparation, and they only come very late in the course of the disease where not much can be done. So individual initiatives, that is what occurs mostly in Ghana. However, some private hospitals and public hospitals have integrated HPV vaccination in their services, but it's not coordinated. And because of that, these are managed independently by the different partners. And in terms of procurement, administration, and follow-up, so the coordination is quite weak. It's not well integrated in our treatment, even though we all know that when women come to us at the clinic, you have to counsel them, and then if they wish and they want to do the screening, then you do it for them. But if we get to a stage as a country where once a woman enters your consulting room, it is routine that all of them are screened. It's part of it. Once they enter, that this will be very helpful, even though not all women will enter the consulting room. But once they enter for some other reason, malaria, um, typhoid, whatever it is a must that they are screened and treated. That way, I think we can get a lot more success. Kindly move on to the next slide. We are getting close to the end of the presentation. So I just want to show you how the vaccination programs in Ghana has been like. In 2006, HPV vaccine had become globally available worldwide. However, in Ghana, there was none. So between 2006 and 2012, there was no HPV vaccination in Ghana. So you can see how these things happen. And then from 2013, the first HPV vaccination project in Ghana was piloted by Gavi. And this is an international group that took up this initiative. And they continued with this vaccination of young women and all that. So by 2018, HPV vaccine pilot project had ended. And in fact, they vaccinated more than 30,000 women. That's about 33,000 adolescent girls were vaccinated. And the issue is that since then, there has not been any national HPV vaccination program, and HPV vaccines are only available in selected health facilities, as I've already mentioned, at different costs. So the facility will decide this is going to be how this is the cost, this is how much I'm going to charge. In fact, we have people who have establish their own programs, and then they charge differently, and it depends on how much they charge. They have to determine it, and because of that, a lot of young women, young adolescents who actually need it have not received this, and that's quite worrying for our country. And so between 2020 and 2023, because of the COVID and all that, things went down. But as I said, in the country, as we speak now, we are still battling with trying to establish a national program that can take care of this. In fact, if we do this, it's a very long-term investment that can help our country. As you cannot, the primary prevention, which includes the vaccination and also education and abstinence. Abstinence, as we all know, is quite difficult, and and when we're in school, one of our professors said sex is a physiological need, and you cannot just say abstinence may not work for them easily. And the use of barrier methods is also quite interesting, and that's very good. Just that sometimes this is also not something people are able to do much before they realize a barrier has not been used. So this is something that we need to be very mindful about. Kindly go to the next slide. And so I show you this just to show that there's no data. I got this also from the country profile since 2021. And we know that HPV vaccination and routine screening can reduce the risk of cervical cancer by actually more than 90%. But as I mentioned, there is no program that is there. As at that time, there's no data to show, because this patchy, if you want to put it, uncoordinated screening that is going on and vaccination are done by individuals. And so data on it is quite difficult, and coverage is quite also difficult to get. And this is something that we need to work on actively. So HPV vaccination is not included in our national vaccination schedule. And this is something that we should all be fighting for, if um, if we get a chance to be on the top, to talk to the politicians and our health program managers as well. Kindly move to the next slide. So in terms of concluding, we think that in Ghana we need a functional national screening program, and all women between 9 and 14 should be a must. We can do this through school, through our schools, and also we can also continue to undertake public awareness and education. That can be very key. And finally, if we can include HPV vaccination into our routine immunization program, that would be good. So screening and vaccination into our routine vaccination program can be quite helpful, and that can reduce the burden of cervical cancer in our country. Thank you very much. At this point, if you have any questions, these are some of the references that I use, and if you have any question, you can ask. Thank you very much.
Thank you very much. I think, Sylvia, you can handle the question and answer session with Prof.
Okay. Yeah, let's just appreciate our prof even as we get ready with our questions. Nice, nice, nice. Thank you so much. So, do you have any question? You can raise your hand to be unmuted or type it in the chat box. And I must say that has really been informative. I feel like I've had a whole lecture on just understanding cervical cancer again. And I'm really looking forward to going through those notes just to reinforce what you have shared with us. So, yeah, is there any question that you'd want to ask?
Okay, so first, I think I have a question. So, Prof, my question is, since we know that the cervix is part of the organs that the would be mother uses in delivery. If a woman has cervical cancer, does it affect the woman's delivery?
Right. Thank you very
Okay.
much for the question.
Some- yeah.
If in pregnancy a woman is found to have cervical cancer, normally we recommend that that woman should be delivered by cesarean section, and this has to be facilitated in the sense that sometimes we don't really want you to get to full term. Maybe by 36, if we think that it's spreading, we may have to deliver you immediately so that we can undertake the care for the cervical cancer, because we know that cervical cancer is associated with huge complications and morbidity, and it can actually lead to mortality within some few um, time. And therefore, we do that, and we also encourage people to do screening. People think that during pregnancy, because of the hormonal changes, screening may be affected, or the results may be affected, and therefore people think it's not recommended. Please, we can continue to screen our women doing screening. If we continue to do that, that is the only way we can get diagnose the some of the preclinical ones. Thank you.
Yeah, thank you very much, Prof. Over to you.
Thank you so much for that answer, that response. Is there any other question we have? So Angela says, Prof, please, you mentioned the barrier method helps in reducing risk of cervical cancer. I thought it being a rough structure could erode the wall of the cervix and lead to increased risk of cervical cancer, but I'm rather wrong, please. So can you kindly elaborate on how it protects against cervical cancer or reduces its risk?
So what I mentioned is that the use of condoms, barrier methods can be quite useful, because if you use barrier method, then, and I also mentioned that HPV is a sexually transmitted infection, and actually some people think cervical cancer is a sexually transmitted infection. So if you can use the barrier methods, then you are not likely to. If someone is having HPV, you are not likely to have it, and therefore you may not get the infection. So that's what I wanted to say by the use of the barrier method. And truly, that's one of the methods that can be used to prevent as a form of the primary prevention, actually.
Thank
So,
you.
Margaret, thank you for that, Angela. Thank you, Prof. Margaret had a question. Margaret, you had risen your hands. Would you want to unmute?
Okay, here is my question. Like the way you say in some cases, for the case of endometriosis, people usually have painful intercourse. So is it the same for like cervical cancer? When you have cervical cancer, maybe you'll experience pain during sexual intercourse.
It looks like the question was not clear. I heard of endometriosis and sexual intercourse and cervical cancer. Margaret, will you want to um, repeat the question or tell me the main point so I can answer? Or if the
Okay, my question was like for the case of something, a disease like endometriosis, we see people having pain during sexual intercourse. Is it the same case for people who are having cervical cancer? Do they experience pain when they're having sex?
all right. So let me mention quickly that, and I mentioned it earlier. When you have cervical cancer and it's giving you pain, then it is totally advanced. It's really, really advanced. Pain during sex is not it's not cervical cancer initially, because mostly you have to think of endometriosis, fibroid, adenomyosis, pelvic infection. Those are the ones that will give you. So once you start getting pain and the pain is due to cervical cancer, then that disease is quite um, advanced, and you would have got things like the discharge, the bleeding, and all those things to come in. Let me mention that cervical cancer is not painful. It's painless initially until it is advanced. So that's what I'll say. Thank you.
Thank you so much for that, Prof. Karen is asking, thank you, Prof. That was very informative. How many cases have you come across in your career, given that vaccination is not that common, especially in your country?
Good. I see that for my practice, I've practiced since 2005. That's when I finished medical school, early 2005. And I've been a specialist since 2010, gynecologist. And nearly every day at the clinic, you see a case of cervical cancer referred to you, either advanced, mostly advanced, and so it's quite common. And if you have the chance to go to the radiotherapy center, you see them plenty. Cervical cancer is common in Kolebu Teaching Hospital where I work, and in Ghana as a whole. And as I said, the second leading cause of mortality and among women, apart from breast cancer. So nearly every day you see one or two. That can tell you that in a month you can see like 30 or more.
Thank you for that, Prof. I think I'm just concerned now that cervical cancer is a very big problem in our communities right now. Maybe I would just like to understand now in the public health sector, especially in Ghana, is it that the government is not able to prioritize cervical HPV screening and now HPV vaccination, or like what is the biggest barrier that we are having at the moment, especially? And I believe that it's not just a problem in Ghana, but most of our African countries. Maybe you could touch on that.
Right. So the government is doing so well, trying to also provide public education. They have been encouraging people through education to go for screening and all that. But since we don't have a program that kind of, that forces women to have the screening and vaccination, that's it. But remember that the vaccine is expensive, and we haven't had a chance to I think they haven't probably prioritized it um, because it's expensive. They haven't probably dedicated uh, program or money to take care of that. Otherwise, we should have we should be able to vaccinate all our women, young women between 9 and 14, and even up to 20. We should be able to do that. But as we speak now, there's nothing like that. And I think that is something that the government is still trying to find partners to look at this, and we hope that in the near future and very soon for that matter, this program may be addressed, especially if we continue to make a little more noise and create awareness and all that. The government may take it as one of their priority programs. Thank you.
Thank you so much for that. We really appreciate. Is there any other question from the audience? Yes. Your time to speak is now or forever remain silent. I see that we have no more question, but I am really grateful, Prof, for this. Like, it's really been enriching, really enlightening and insightful. And maybe for those who may want to keep the study, maybe we can go to Ghana, and people from Ghana, you can come to Kenya. We see how we can have exchanges just to understand more about this cervical cancer. And I really hope that as we're continuing, as we progress, we're going to have greater impact. Like now, from what we've just learned, let's keep spreading awareness. Let's demystify the myths around HPV vaccine. And as we are aspiring to be public health, in the public health field, let's think of how we can mobilize for resources even when we got there, so that we can have more programs in the community. Yeah, thank you so much, Prof. So now I would love to hand the microphone back to Jason before we complete. We are almost done.
Okay. Once again, Prof, thank you so much for joining. Thank you so much for the knowledge that you shared. And I'm sure we've all learned so much from these sessions, both from Mr. Gideon and Prof as well. And we've been able to see the state of cervical cancer in both countries, and we see the similarities, we see some of the differences, and we see where we can improve together. Please, Prof and Mr. Gideon, please, if you are still on the session, is there any way, maybe through an email account, that if any interested participants would like to reach out to you or would like to collaborate on a research program or for anything of that matter, is there any email account or email address that they can reach you on? Okay, okay. So
Well, I've
Prof
said
has
my
put.
yes, that's my email account. Thank you.
Okay, thank you very much, Prof. So Prof has placed his email account. And please, Mr. Gideon. Yeah.
I may not be able to type, but just follow me on LinkedIn. I can be able to share my email by that. But I will also share with you. Then maybe you can share with the rest of the audience.
Okay, so for Mr. Gideon, you can reach him on his LinkedIn account. So you can just search for his name. You can just copy his name from the flyer, and you can search it on LinkedIn, and you can reach out to him there. So Thank you all so much for joining. Um, would like to invite Victor to come and give us the vote of thanks. Okay. So Mr. Gideon has also placed his email address. Yes, Sylvia.
Okay, just before we get the vote of thanks, I'd love to really encourage us. We have the flyers. You can share it on your socials and just type what you have learned. Let's keep the conversation going and tag FGMSA, Msake, Scope Heroes. You can tag the speakers online so that we can keep the conversations going. Yeah, thank you. You're welcome, Victor, for the vote of thanks.
I'll greet you all. Good evening to our guests and our speakers tonight, Professor Kwame and Dr. Gideon Gachihi. Thank you for dispensing the knowledge and taking your time to join as young to-be professionals and sharing your knowledge with us. It's been a great honor to learn. We are happy that we've learned something. I've personally learned a few new things, and maybe I'll continue learning and sharing that which I've learned. And all of us, for those who came, were able to attend, thank you for your time. And whatever you've learned, don't just keep it, share with the rest. And with that, we can maybe help eradicate these huge giants that we're facing. I recently lost a neighbor to cervical cancer, and we hope with us will be the change we want to see and help in improving this public health, spreading it, and maybe bringing more light into this and help eradicate it. To our two speakers, asante sana for sharing with us, and may the good Lord continue blessing the work of your hands, and maybe through you, we can be able to move more steps in the right direction of eradicating cervical cancer. Thank you.
Thank you very much, Victor. Victor is also an executive of SCOPH-ICRF. And we'd like to say a big thank you to everyone for joining. We'd like to thank you for participating. And we'd like to thank most especially Prof and Mr. Gideon for gracing our occasion. And we know you had so many things you could have done with your Saturday, but you decided to spend time with us to educate us and to teach us. And we thank you so much, and we thank everyone for joining. As Sylvia said, let's keep the education going. As Mr. Gideon and Prof stated, that we need to keep educating, and that we are also stakeholders in the cervical cancer fight, even as medical students. So we've created the frames, and the frames we used for the campaign towards this webinar. The frames will be made available again. You can still put your picture in the frame, and then you can type a message on your WhatsApp, on your social media, or your LinkedIn, and you can share what you've learned or what you want to tell the audience about. You might never know who you might be able to reach out through your social media. That's another way we can also educate. So once again, this was a collaboration between MSAKE, that's Medical Students Association of Kenya, SCOPH, and Federation of Ghana Medical Students Association, SCOPH. And we like to thank you once again for joining. As they say in Swahili, asante sana. As they would say in Ghana, medase. So asante sana, medase. And we also learned a few words from Kenya and also from Ghana as well. So thank you all for joining. Oh yeah, Mr. Gideon, please, you can unmute us. Okay, okay, okay. Thank you all for joining. Okay, okay. Thank you all for joining. You can send a few stickers before you leave. And see you next time. Bye bye.
Bye. See you in Kenya.
Oh, we like to visit. We like to visit. Thank you very much. Bye.